follow our Instagram. And now we're recording. All of these sessions are recorded and put on YouTube with our channel VT Reach, and you can follow us on Instagram at VT Reach as well.
So tonight for our 11th session, we are featuring the Limb Salvage Team, and we will be hearing from Lara Stone and Stephen Merena, who are two podiatrists, as well as John Bullis, an infectious diseases physician, and Katelynn Ferranti, a vascular surgeon. So it'll be a great session, and we want to thank these wonderful healthcare professionals for speaking tonight, and thank you for everybody who is joining us. So without further ado, we can get started with our first speaker.
Hi, I'm Lara Stone. I'm a podiatrist. My inspiration into medicine, I always really liked science classes growing up. I liked art classes, anything where I could use my hands and make things. I took an anatomy class in high school that I loved. A lot of women in my family are in medical and science fields. My mom's a physical therapist. My sister's a nurse, cousin and aunts who are nurses and doctors. So that had a big influence on me. And I always just knew I wanted to do something that would help people and make people feel better. I grew up in West Virginia, and then I went to undergrad at Williams College in Massachusetts. Williams College is a liberal arts school, so they really encourage you to take all kinds of different classes. You can sort of do whatever you want to do as long as you compile enough classes to major in something and graduate. So I started off thinking I wanted to be on the pre-medicine track. I took chemistry, I took some English classes, psychology. Wasn't sure about chemistry after I finished, so I started following the English class track. Thought I might want to go into journalism. Took some psychology classes that I loved, so I ended up majoring in that. And Williams has a pretty great thing where in January, for the month of January, every year you do a winter study course, and it's a pass-fail course, so no pressure. And they offer things from glass blowing to Japanese films. So my sophomore year, I took a winter study class to explore the field of teaching. I did some tutoring in New York City. Made me really appreciate teachers and how hard they work. And the influence they have on kids, but it wasn't quite the right fit. So my junior year, I took a course where we could shadow anyone in medicine. And I shadowed a primary care physician, thought she was great. And at the same time, shadowed my sister, who at the time was a nurse practitioner in women's health. Really liked what she did, liked the procedure-based aspect of her career. She saw a lot of acute visits where you're seeing patients, you come up with a treatment, and they pretty immediately get better. I really liked that part of it. So I started kind of going in that direction. And my senior year of college, I drove by a podiatrist's office, went home and Googled what's podiatry. And that sounds interesting. I shadowed her for the month of January, my senior year, and loved it. Liked everything she did in clinic, lots of office procedures, kids, 100-year-olds, sports medicine, diabetic foot care. Really thought what she did in the operating room was really cool. So that's when I decided to go into podiatry. So my last year of college, I finished my pre-med requirements, all except one, because I still wanted to have some fun. My last year, I took art studio classes. Took my organic chemistry course at home over the summer after college. I went back to West Virginia and took that course and worked at Wendy's and lived with one of my best friends from high school and had a pretty great time. Before that, I had applied for this job at the Williams Club in New York City. So I worked there the year after college doing event planning, and that gave me the time to take my MCATs and apply to podiatry schools. Podiatry schools, there are 9 in the country, located all over the place. If you go to the American Association of Podiatric Medicine website, they list them all and tell you about it. But it's essentially, it's a 4-year college, same requirements as applying to medical schools. The first 2 years, it's a lot of basic science classes. And then the second 2 years, it's more clinical work. With the last year, you're doing a lot of what they call externships, where you're visiting different residency programs, seeing what type of podiatric medicine you might want to get into. And then you go through the match program like you do in medical school, where you list your residencies that you want to go to, residencies, list students that they're interested in, and then you match. So then I wound up at Roger Williams Medical Center, which is a 3-year podiatric medical residency, kind of focusing on all the really bread and butter stuff of podiatry. And then I came here. So after finishing my residency, started work here at the University of Vermont Medical Center. I'm a podiatrist in the Department of Orthopedics and also an assistant professor with the university. During my first few years, I gathered enough surgical cases to complete my board certification. So to do that in podiatry, you need a certain number of cases that you submit, and they're scrutinized by the board, and they tell you whether or not you pass, and there's a written portion of that as well. And once you pass, you're board certified, and then every 10 years you have to take another test. There are a lot of different things that podiatrists do. Working at the medical center, it's mostly clinic-based. We're in the clinic a lot, 3 to 4 days a week, seeing patients all day. You see a variety of things, heel pain, hammer toes, bunions, foreign bodies, all kinds of stuff. So it's really interesting. See kids, see 90-year-olds. We also provide inpatient care at the medical center. We work with the orthopedic residents. There aren't podiatry residents. There's not a podiatry residency in Vermont. So we work with orthopedic residents. We mainly get consulted on diabetic foot infections. So we help manage those patients. We also do some teaching with the orthopedic residents, some medicine residents, medical students. We have people shadowing in our clinics. We do some lectures, and then in the operating room, usually for elective cases, a couple of times a month, and then for whatever inpatient procedures pop up, we cover those, and do additionally some academic activities in the department. And kind of what work-life integration looks like. It's about 40, and it varies, 40 hours a week. Our clinics run from 8 a.m. to 4:30 p.m. When you're in the operating room, you start a little early, you're there a little before 7. Sometimes with different academic meetings, you're starting earlier and running later. The university has a weekly administrative day that gives you some flexibility. Use that time to catch up on writing notes, calling patients back, reviewing imaging. It's also a good time to add on any inpatient surgeries that you might have. So it does let you move things around a little bit so you can get everything done. And outside of work, I love basically anything that gets me outside and lets me move around. Having a great time watching my son grow up with my husband. He's also thinks feet are pretty cool. That's him in the bottom there. So pretty great place to live, to do the things you love, anything outside, and great people in Vermont.
Thank you so much, Dr. Stone. And now we'll have Dr. Merena speak as a podiatrist as well.
Right, thank you. So I'm going to try to not be too redundant. You'll see certain things that I say will be similar to what Dr. Stone's experience was like, but as you'll see, I've been in practice a bit longer, and so I'll try to maybe share a little bit more of my insights on that side of things, as opposed to kind of repeating the education piece. The inspiration as far as getting into podiatry, I had my share of injuries playing soccer and long distance running. So the sports medicine side was interesting. My dad, who was also a runner, had a very positive experience with podiatrists close to where I grew up in New Jersey. This podiatrist happened to be the team physician for the New York Giants, and I had an opportunity to shadow him when I was kind of thinking about a career path, and had a very positive impression. So that sort of led me towards this path, and And also just having that, feeling that if I'm going to do something with science, doing that to help other people was a kind of driving force behind getting into the healthcare just in general. Next slide. My path, as I mentioned, I grew up in just outside of New York City, went to undergrad at a small town out in Western Pennsylvania near Pittsburgh. Anybody's out that way, there is in Indiana, Pennsylvania. So IUP is where I got my undergraduate in natural sciences. My dad was a chemist and had an influence on me, kind of having, I guess, a certain affinity. But I can't say I was really enamored with chemistry, but biochemistry and the biological sciences definitely caught more of my eye. And when you took the upper level classes of physiology and anatomy, then it really kind of hooked me in. As with Dr. Stone, went on to Podiatry College in Philadelphia, which is now Temple. And then moving through, we did the same residency program, but I did it a few years earlier. And back in the day, it was only a 2-year residency program, focusing on medical and surgical management of foot and ankle problems, and really a combination of both managing inpatient, really spending quite a bit of time in the operating room, and then getting as much opportunity in the clinic setting just to kind of tie things together. Next slide. Board certification, as Dr. Stone alluded to, it's kind of an essential thing if you're in any field of medicine. Board certification, which you'll hear from all the speakers tonight, is essential. So that's something where it really it's a way of making sure that the quality of the provider is there, and that the experience and what they're able to offer the public has been kind of scrutinized. So it's important to be able to achieve board certification. As far as my career path after coming out of residency, I originally came to Vermont in 1999 and was down in a smaller town south of Burlington, Middlebury. Middlebury College is kind of the main thing there, and I worked with another podiatrist for about 6 years. So that was a private practice, and I learned a lot, not just from him, but also really how to run a practice, which they don't really teach you in your training leading up to this point, unless you go out of your way to kind of look at that. I branched out and ran my own practice thereafter, coming up closer to University of Vermont, just a 10-minute drive away. Did that for about 5 years as Champlain Valley Foot and Ankle. Started to get to know the University of Vermont landscape in the orthopedic department, and in 2011 made a transition to where I elected to join the orthopedic department and kind of switch from private practice world to the academic world. And there's definitely pros and cons when you look at private practice versus academic practice. But I thought at that point in my career, it was a nice change. And, I was happy that, the podiatry would afford me to be able to make that type of transition. If you go to the next slide. And you still have the clinical responsibilities, you still have the surgical responsibilities. And as Dr. Stone alluded to, quite a diversity. It's, limb salvage is one part of what we do as podiatrists, but there's a lot of other things that we treat as well. The academic side really gives you the ability to increase your footprint with teaching, with doing scholarly type work, which I find very valuable at this point in my career. So nice to be able to have that opportunity. Next slide. So, currently 3 days a week, clinic, full days, same hours as Dr. Stone. We kind of work in the same area. Try to get in the operating room, once a week, with some variability. There's some flex between operating room time and sometimes an extra clinic day. And then as mentioned before, the administrative day, which really gives you also a certain amount of ability to kind of fill in gaps and have that flexible time. I have a wife and 2 kids. My kids, I guess they can still touch their feet like George did on the other picture there, but they're a little older. I've got 2 in college, and but growing up, had plenty of time to spend with them. Coached soccer for years, played hockey for years, and really just enjoyed the Vermont experience, which is, as Dr. Stone alluded to, is really getting out and enjoying the outdoors. So able to kind of really get that work-life balance, which I think is pretty important for anyone who is going to be a caregiver. Next slide. Just a couple of quick slides since we're talking about limb salvage. So I just put these together. What does a podiatrist do when it comes to limb salvage? So evaluation and risk assessment of an at-risk limb. PAD stands for peripheral arterial disease. So looking to make sure that the limb has appropriate blood flow. If they don't, got to get the vascular surgeons involved. Assessing for loss of sensation or peripheral neuropathy. Really assessing how the function of the foot is from a musculoskeletal standpoint, the biomechanics of how the patient walks, and just making sure there's no skin changes. Next slide. Preventative care, patient education is very important if you can kind of stop the problem before it occurs. So things as simple as smoking cessation, appropriate shoes, just showing patients how to care for themselves, and that intervention goes a long way, and that's something a podiatrist tries to keep with their patient care with limb salvage in mind. Next slide. For folks who develop wounds, podiatry is very involved with assessing how bad is the wound, dealing with the wound or debridement, choosing appropriate intervention with dressings, and determining what activity level is appropriate for the patient. Next slide. And then dealing, and you can kind of click so the pictures come up. I'll try not to gross everybody out. That's a good one. So, surgical management, you can kind of break down. If you look in the picture in the top right, you can look at it as a correction of deformity. So with kind of the left picture, you can kind of see like kind of a wide foot, and then a couple of screws in the right picture x-ray where it kind of narrows it up, and that can be helpful. Bad infections, having to clean up those infections, which can be limb or life-threatening, and being able to take those into the operating room. And then when appropriate, deciding if you need to, for the greater good, amputate, and sometimes it's just a toe, but unfortunately sometimes it's more. But the idea is certainly limb salvage, which is to keep as much as you can. And I think that's all I have.
Thank you very much. And next we'll hear from Dr. Bullis and his inspiration into medicine.
Thanks, Steve. I think my pictures aren't quite as cool as yours, but I've got some at the end. So yeah, I think I'm the only, among the panel here, I'm the only non-surgeon, but I'll sort of talk about, how I got into medicine. And so for me, I guess I went to college. I was just sort of assuming I would study science because that's like what my dad did. And I got into biology. I wasn't a huge fan, honestly. And, my big passion at the time, and it really still is one of my biggest passions, is music. And so I fairly quickly gravitated towards jazz performance here at UVM. I went to UVM, and so, yeah, sorry, I wasn't sure if I should be on the next slide or not, but I guess this is still inspiration. But so for me, I was, doing music for a while, really loving it, really enjoying it. But then I just thought, I think the lifestyle was going to be super hard. I mean, I think it's one of those things where you really have to be the best of the best if you want to make a lifestyle of it. And so I quickly got back into science. I still played music, I still studied it in college, but I quickly got back into something that I think I too liked. Similar to Steve, I liked more than biology, which is what I started out with, but it was biochemistry and like medicinal chemistry and more of the the application to health sciences. So got back into that, started working in a pharmacy because at one point I was flirting with that idea. and wasn't a huge fan of at least retail pharmacy. And so basically then, I think started thinking more seriously about medical school. And for me, I guess, having really no one in the family in medicine, it was I didn't really have anyone I could go to. My grandmother was a nurse, so we always talked a lot about that, but other than that, I didn't really have much experience. So I had a few jobs at the hospital here at UVM that got me interested in medicine, and specifically ID. First, I was a patient, what they call a patient sitter or a patient attendant. And that was just sort of, you would basically sit with patients that either were confused or potentially could be kind of not quite violent, but I mean, they could pose a safety risk. And so that was interesting. It was a lot of sitting around. It was a lot of redirecting people. And then I quickly moved on to working as an anesthesia technician. So you would go in between surgical cases that many of these fine people here do. You would sort of turn over the room and replace certain things. And that was something very different. That was also something cool. But I think what it really was that solidified my interest and sparked the interest in ID was actually working in the ID clinic here at the hospital. And I got a job as a medical assistant and just kind of immediately loved it and found that sorry, this might be straddling the two slides, but immediately saw that a lot of these doctors really were what's very commonly described as like detectives of medicine. So you would basically be stuck or faced with these pretty challenging scenarios and have to look at the whole patient and try to look at a whole bunch of data and try to figure out what's going on. And that seemed to be whenever you hear someone talk about ID, a lot of people like to throw that term around, like a medical detective, because there's a lot of common stuff like every other specialty, but there's a lot of that sensation of sort of getting to the bottom of a really challenging case. And so, yeah, like I've already mentioned, I studied biochemistry and music a little bit too at UVM. And then I didn't go far. I just went to UVM for medical school with a year in between doing those jobs I mentioned. And then stayed here for internal medicine residency, which is a 3-year program. And the nice thing is a bunch of my classmates stayed here too for internal medicine residency. UVM residency does like to keep medical students who are interested in internal medicine and probably other specialties too. So I stuck around, and then after residency, you can decide if you want to call it done with your training, and at which point you could either perhaps practice in primary care, or you could practice as a hospitalist, where you see patients in the hospital and of all different varying types of problems. Or a lot of other people use that branch point to further specialize. And so for me, it was infectious disease, but others, it might be cardiology or nephrology, it might be intensive care, pulmonary. There's a whole gamut, rheumatology, all sorts of stuff. So like I said, for me, it was ID. And that is here at UVM, a 2-year program. There are places where it's 3 years, but at the very least, it's a 2-year fellowship program. So yeah, I guess I already said this, so apologies. But yeah, I guess we can just skip over it. And then, yeah, I was thinking more about this. So what do we do? I would say, like I said, we are non-surgeons, we are non-proceduralists, which for me is, I like. And we are, I guess you could say, more of a cerebral specialty. We like to wax poetic about things for long periods of time. But getting to the actual actual things we do, we spend, I think we're one of the only remaining specialties that spends a considerable amount of time both in clinic and in the hospital. And in clinic, we take care, we do, manage longitudinal care, meaning we see people for months and for years, sometimes with chronic infections, things like HIV, hepatitis. We see patients who are newly arrived to the United States and do exams and see those patients. So we do a lot of that type of stuff. And then in the hospital, we are involved in I think one of the big draws for me is we're involved in consulting on patients from essentially every different specialty. So while we're talking about podiatry and vascular type stuff tonight, we see patients in the intensive care unit on neurology and on cardiology. And for me, being an adult doctor, the only group I don't see is kids, but we're intimately involved with all sorts of specialties. And I think that's very refreshing. I think for me, it helps, keep things very fresh. And you might be seeing, 10 diabetic feet on a Monday, and then on Tuesday you might be seeing a bunch of people with pneumonia or patients who are pregnant. So that's a huge draw for me. I think we can go on. Oh yeah, and so I just threw in a bunch of pictures just to sort of give people a sense of some other things ID will do. And just actually, sorry, stepping back to the last one, you don't necessarily have to go to that slide, but other things you can do in ID, I think that's important to highlight. So a lot of people go into public health and epidemiology and examine, what types of infections are causing problems in a state or a country. And so that's super important. Some people focus on STDs and HIV and, sexual health, that type of stuff. Some people get involved in global health. Antibiotic stewardship is a really big thing in infectious disease, where you try to preserve antibiotics that are extremely overused just in modern society. You try to limit that because you want to make sure that in 20 years we still have options. And so that's a growing threat. So those are just some of the other things you can do. In terms of some pictures, so these are just a bunch of patients who've had complications of HIV. And like I said, HIV is something we deal with a lot in infectious disease. Thankfully, we don't see as much AIDS as was seen in the 80s and the 90s, and really owing to better medications for HIV. But these pictures alone are just from the past couple of years of patients who have unfortunately either been newly diagnosed or not been taking medications for HIV for any reason. And so these are various things. And so the top three are basically just showing various types of infections. The one on the left top is a brain type infection caused by a certain yeast. And then the middle is, you can sort of get a sense that's a lung infection. And then on the far right, on the top, is a sample from that same lung infection. And so those are complications. And the reason people get these things is, HIV gives you, it weakens your immune system. And so you're more susceptible to things than you would be without it. On the bottom, two other what we call opportunistic infections. One's another brain infection called toxoplasma, and then one on the bottom right, that enormous looking thing on the right of the picture. This is a CAT scan looking at cuts through someone if you sort of sliced them from top to bottom, and you're looking as if their feet were sticking out of the screen. But so on the left, you see the person's liver. On the right, the big thing here is the person's spleen is enormous, and it's filled with something called MAC. And so that's another infection people get with HIV. I think we can go on. And then just a couple cool ones. This was some person I saw a couple of years ago, I think at this point, but one thing I think I forgot to say, we in ID do a lot is really, really, really dig into what's called the social history of a patient, which is, exposures to really anything. It's where you live. It's if, you're sexually active, if you use drugs, if you eat certain things. And so we really pride ourselves on that, because sometimes, as was the case with this patient, we figured out he was boar hunting down in Florida, which is something I guess they do in Florida. And he got this fairly rare, almost eradicated infection that in the United States called brucella. So that was a really interesting one. And again, the key there was just asking the right questions. We can go on, please. And then similar type of case, rather than a boar, this one was from a rat, and this was actually down at North Beach. So, you can get weird things in Burlington, Vermont. This was a patient who got something called rat bite fever. Not surprisingly, he got bit by a rat. The name sort of tells you everything, but similar type thing. I might have one or two more. This is a person who was spending a lot of time in caves and having exposure to bats, and so developed a lung infection called histoplasmosis. the lungs are normally supposed to look nice and sort of black throughout, but they're sort of peppered with white. It looks like there's just all these small dots all over. So he got an infection from some exposure in a cave. And I think the last one is some echocardiograms. So these are what's called echocardiograms, or basically ultrasound pictures of the heart. And as probably everyone in the call tonight is intimately aware with, we have a huge opiate and injection drug use problem, and people who suffer from opiate use disorder. And so these are pictures of some of the complications, some of the worst complications, where you can get infection landing on your heart valves, and then the heart valves don't work anymore, and people can get extremely sick. They can need their heart valves replaced. So these pictures, hard to get a sense when they're not moving. It's just a static image. So it's like, what am I even looking at? But basically they're showing that on the left, there's a thickening of a valve, that sort of thick thing that's pointing out between the dark black. And then on the right, there's a bunch of color, something called Doppler. And so it's basically just demonstrating that blood is going in the wrong direction. And so that's just another thing we see a lot of. So like I said, while the focus tonight is on, infections and podiatric infections and stuff like that, those are just some other things you would probably have some exposure to if you went into infectious disease. Sorry if I went over there. Work-life integration. So yeah, I think I kind of alluded to this. Here at UVM, we have a couple different consult teams seeing new patients. We do a lot of teaching. Admittedly, with COVID, a lot of it's turned to Zoom, but it works out okay. We have 2 ID fellows currently, and so there's 1 ID fellow per year. And I just finished my training here actually last year. And then family-wise, for me, or outside of work, I like to spend time with my family, as everyone basically else has said. And also, like I said, love to still play music, get outside and read. Those are kind of my favorite things. Yeah, thank you.
Thank you so much, Dr. Bullis. And now we have Dr. Ferranti talking about her inspiration into medicine.
How's it going, guys? So I'm one of the vascular surgeons at the UVM Medical Center. My inspiration to medicine actually began in college. I was really interested in math and science classes. And one of my mentors in my science classes got me really involved in outreach, working with some inner city students in Hartford, Connecticut. And I really loved working with the students and teaching health and science to these kiddos. And so I actually was really interested in becoming a doctor so that I could be a pediatrician. And so that was sort of my inspiration into sort of leading me down a medical path. And so I did my undergraduate studies at Central Connecticut State. I double majored in biomolecular science and math. I stayed there and got my master's in biomolecular science. And sort of at the same time, I did a couple of different things. I did a lot of tutoring. I waitressed, and I got a EMT certification, which sort of helped me get a little bit of a better handle on some exposure to medicine. I also worked as an emergency department liaison, sort of helping with patient issues and making sure that their concerns were addressed. And I did all of that prior to coming to UVM for medical school. When I was in medical school, I was really excited about my pediatrics rotation. And when I did my peds rotation, I actually found out that when you take care of a pediatric patient, you actually also have to take care of their parents too. And so you ended up with about 3 patients when I was only planning on taking care of 1 at a time. And so that sort of made me realize that maybe pediatrics wasn't quite for me. When I did my surgery rotation, I was just blown away at how cool it was. And by chance, I was on the vascular surgery service. And I thought that the sewing of blood vessels together was just really elegant and fascinating, and took a lot of technical skill. And I was like, I want to sew like that. I want to learn how to do what those guys do. So that sort of got me interested in vascular surgery. And I also found the patients challenging kind of in a good way. So those are all the things that sort of led me into vascular surgery. There's kind of 2 ways that you can get to be a vascular surgeon. You can do a general surgery residency and a vascular fellowship, or you can do an integrated surgery residency, which basically is kind of like, people think about it as taking the shortcut to be a vascular surgeon. but it's kind of nice in that you kind of really get 5 years worth of vascular surgery instead of just a little bit in general surgery and 2 years in fellowship. So that's how I got to being a vascular surgeon. Right out of residency, I was hired here as a vascular surgeon and an assistant professor of surgery. And then sort of when you just start, you work on your boards. And so there's, for the vascular surgery boards, there's a written component. Once you pass that, then you get the opportunity to sit for the oral boards where senior vascular surgeons basically go through scenarios with you and make sure that you know the right answers. So as far as responsibilities go, we work on arteries and veins. We can sometimes fix them from the inside, which is an endovascular surgery that's a little bit usually less invasive. Alternatively, there's open surgeries that we do to fix arteries and veins. We see patients in a doctor's office setting or a clinic setting. We also see patients in a hospital setting. We interpret imaging studies, mainly vascular lab studies or ultrasounds, but we also need to know how to interpret CAT scans and perform and interpret angiograms. We do a lot of wound care. We also do minor and major amputations. And then in the academic setting, which is where we all are, we do a lot of resident medical student education for vascular surgery here. There's a vascular surgery fellowship, so we teach the fellows as well. I'm involved in the vascular surgery simulation, so I set that up for our residents and fellows too. And this is just a picture sort of comparing some of the different ways that we can fix blood vessels. So this on the left is an abdominal aortic aneurysm. Ideally, your aorta should be a straight tube. There shouldn't be this swollen area. The kind of old-fashioned way that we fix that, and we still do sometimes fix it, is making a big belly incision, moving all your intestines out of the way, and then clamping your aorta above and below where the aneurysm is. And then we basically replace that segment with a tube graft. So that is a pretty big surgery. You're clamping the biggest blood vessel in the body, and patients usually take a while to recover from that, at least a week or so in the hospital. And then usually people don't feel back to normal for at least a month or so. The other option, which is all the way on the right, is a stent graft called an endovascular abdominal aortic aneurysm repair. And those patients come in, have surgery, and go home the next day. So it's really cool to see the evolution in medicine and the technology. You can do the stent graft with basically 2 1-centimeter incisions in patients' groins. So that's really neat. And then some of the other surgeries that we do, you can see the aneurysms again on the right, but on the left, which will actually get a little bit more to the limb salvage part. So people can get blockages in their arteries in their legs in the same way that they get blockages in their arteries of their heart that gives them heart attacks. And so there's different surgeries that we can do to improve the blood flow to the legs. So the ones here are different types of bypasses that we do. So kind of similarly to how people get open heart surgery and open heart bypasses, we can do bypasses in the legs to improve the blood flow to the legs so that people can heal wounds, or it can improve if they have pain in their foot. As far as work life goes, my schedule varies between 40 hours up to 60 hours, depending on what our call is. Usually for vascular surgery, we end up taking a call 1 day a week or 1 weekend a month. My Mondays, I do sort of more of the minimally invasive procedures in the cath lab. Tuesdays, I have clinic, and then we have our resident and fellow education. Sometimes that's in the simulation center also. Wednesdays, my catch-up day and paperwork day. Thursdays, I spend all day in clinic, and then Fridays are my OR days. And as far as outside of work, I really like to paint and bake, and I play with my rescue dog and spend time with my family.
Thank
All
you
right.
so much. Yeah.
Thank you, everyone. So if anyone in the chat has questions, please ask them. Lily and I will be asking them as we go. And to start us off, I was just wondering for really all 4 of you to speak about how COVID's really impacted your job and the way you see patients. I know specifically on the limb salvage side, we've heard about COVID toes and COVID causing problems with vasculature. So I'd love if you could speak on that. And anyone can speak.
I guess I'll just talk for a moment. I would say, the one thing that kind of transcended through COVID would be patients who actually had like a high risk limb salvage problem, because you can't really not care for those patients, because they'll generally deteriorate and get worse. So, example would be if they have an open wound on their foot, and if they are kind of off the radar and not being cared for, they're eventually just going to get sick and end up in the emergency department. So at least, through COVID-19, I would say the one patient that stayed on my schedule, a lot of other people rescheduled or, got postponed, but not the limb salvage patients. Those kind of held true throughout.
I think from a vascular standpoint, there were some patients who probably waited at home a little longer than they should have, but ultimately folks who have really significant wounds or really bad peripheral arterial disease ultimately ended up in the clinic or in the emergency department for us to see. Initially with COVID, there were some delays in certain procedures that were considered elective procedures, but procedures that were emergent or urgent were still being performed. And then they kind of looked at that to see that, well, maybe for certain types of surgeries, we should probably still be doing the elective ones, because those are the ones that are preventing other people or other complications afterwards if they don't have the surgery. So right now, I think we're doing more surgeries than they're doing at certain other centers.
I think for us, it's probably been just actually figuring out what it is and how to treat it. I mean, it's irrespective of at least what we're talking about tonight. I mean, it's like, back in March of 2020, I guess, we would just have these meetings and just, as in the whole department. And it's just funny how it's evolved so much, and you're trying to manage everything at once. And I think thankfully things have gotten to the point where we're much more comfortable with things. But early on, all the questions were like, how do I get my patient a test, or what treatment can I offer them? And I still remember one of my first memories was, I think it was getting called about, a patient who'd had fever, and his wife went into labor, and unfortunately we had to tell him you can't actually go, because he ended up being one of the first patients in the state who turned positive. So, I mean, it obviously impacted everybody on this call tonight, everybody's life, but it just figuring out, trying to learn what this thing was as it was unfolding. So, I mean, and everybody's heard this. And then also, I think a big thing has been dealing with misinformation and getting people vaccinated. And, so obviously just figuring out what it is from a more like logistical standpoint. I think it's essentially made us move very, very heavily, as probably with a lot of people, a lot of other clinics, but using this very platform to see patients. I think Zoom appointments are tremendous in many ways, unless there's something that really needs to be addressed in person. But a lot of our patients, for whatever reason, have just preferred to do Zoom. And so it's something that we are doing a ton of in clinic. And like I said, I really love it. Yeah, I think logistically that's kind of been the only big change in how we operate on a day-to-day basis.
Okay, thank you. And we have a question from the chat that is for all of you to answer. And it says, how close do you typically get to your patients? Is your work primarily outpatient?
I wonder if we could I'm not totally sure the how close part. At least speaking from an ID perspective, we, like I alluded to, we do both inpatient and outpatient. We have at least, I think I have about a day and a half of clinic myself every week. or not every week, I'm sorry, not when I'm on service, but most weeks. And for at least ID, it's chronic infections. Another thing I also do, I'm in charge of our travel clinic, which again, with COVID, it's not really that busy right now, but travel counseling is another thing that falls under the ID umbrella. So, but I think for us, it's pretty good, like 50-50 inpatient, outpatient. It's probably not true for everyone in ID, but I think that's kind of how I am.
And we're typically in the outpatient, so seeing patients in our clinic outside of the hospital 3 to 4 days a week, and then seeing patients in the hospital we see as we get consulted. So maybe over there once or twice a week, and sometimes not going over there for a whole week. Sometimes you're there every day. It just depends on how busy our kind of patient load in the hospital is.
So for vascular, I see clinics in it, or patients in an outpatient clinic about 1.5 days a week. And then the majority of my time otherwise is spent in an inpatient setting. So either seeing patients who are admitted after they've done surgery, or after we've done surgery, or patients who've come in through the emergency department who need to have a vascular procedure. And then as far as how close we get with patients, there's certain patients in vascular who I see them more often than they see their primary care doctors, depending on what their vascular issues are. So it's, I think a vascular patient says, once you're a vascular patient, you're a vascular patient for life. So we see those patients basically throughout the rest of their life. And I'm not sure, that's probably pretty similar for you guys for also, but.
I would say, it's a percentage of patients, it may be kind of you see them once, you give them, their advice, maybe you would stratify them as a low risk patient from a limb pathology that could lead towards limb salvage. But if they kind of make lifestyle changes, improve their glycemic control with their primary care physician, then maybe I don't have to see them very often. But you get to know certain people really well, sometimes unfortunately, and I've had patients that I've been following for a decade, sometimes very often, depending upon, the acuity of the problem that they present with.
Thank you. I have a question too for just podiatry in general. How much overlap is there between podiatry and orthopedics? I know you both talked about it a little bit.
You want me to tackle this one, Laura?
Sure, go ahead.
All right. So, so podiatry are foot and ankle specialists, and you are making the decision to become a podiatrist essentially 4 years earlier than you would otherwise if you went down an allopathic path. So if you apply that to orthopedics, an orthopedist who may become interested in specializing in foot and ankle would go to medical school at the same time you were in podiatry school, but then get into an orthopedic residency. And then even on top of that, they may do like a fellowship year specific to foot and ankle. Are there differences between a podiatric surgeon and an orthopedic surgeon that is specializing in foot and ankle? I think there are strengths and weaknesses. For example, I would say that orthopedic colleagues that we work with, their trauma training is they have more rigor with their trauma training than most podiatrists do. Although podiatry training can vary from residency to residency in the sense of what you're exposed to and what you come out with numbers wise, and where your confidence is. I think diabetic limb salvage tends to be more in the realm of podiatry than orthopedics, but they can be part of the team as well, depending upon what's going on.
Okay, thank you. And there's another question in the chat for all of you as well. And it says, what case or patient did you find most interesting or most memorable? Which is definitely can be as specific or vague as you please. I'm sure that there's so many cases you've all seen, but if there's one that stands out right now.
I would probably, I mean, I think, yeah, it's a tough one, but I think I would probably say that one of the patients was the one I shared some of the images, but it was essentially it was, you know, really sad. It was a young guy who had still was bearing a lot of the stigma of HIV and wasn't taking his medicine. And so he essentially got AIDS. And so when that happens, almost as a rule, you will get at least one, if not 5 or 10, what's called opportunistic infections. And again, things that really shouldn't cause infections in healthy people. But when your immune system stinks, you know, it wreaks havoc. And so I think he was the most memorable in that he taught me that principle, because we don't thankfully see as much AIDS as we do anymore. And also, you know, that there still is a lot of stigma. And another thing, just that, again, you just have to see the whole patient and be wicked thorough with a lot of these patients, because, you know, he had, like I said, probably at least 5 different things going on. And unfortunately, did die. But yeah, so I think he probably was the most, you know, most challenging and also most memorable patient, at least of mine to date.
So I have a couple interesting and memorable ones, but mainly they're involving aneurysms. So the pictures that I showed before are of aortic aneurysms. And ideally you fix them before they give the patient trouble. But if the aneurysm gets really big, it can burst and people can bleed into their bellies. Some people, well, most people don't make it to the hospital. That's how much bleeding they have. But for those that do, we have the opportunity to try to fix their aneurysm. And so I think I was attending for maybe a month and a half and I had my first rupture. And we put an endovascular stent into him, and he actually went home like 3 days later, and he came back to see me in clinic, and he gave me like a big hug, and he said, you know, thank you, I got to hold my grandson. So that was a really cool case. I've had a couple other aneurysms. I had another gentleman who had a splenic artery aneurysm. And he was really young. He came in, he was really sick when he came in, and I was able to put some coils into the aneurysm to stop the bleeding or to slow down the bleeding. And then one of the trauma surgeons actually helped take his spleen out to get rid of the rest of the bleeding. So that was a pretty cool case too. He came back in and was walking around doing great. So.
I thought of one that I think of regularly when I see toothpicks. I had a young kid that stepped on a toothpick. He liked to make big toothpick forks, so he had them all over the place, and he stepped on one and it went pretty deep into the foot, and was in the emergency department a few times for it, and they couldn't get it out and had all this imaging, MRI. So we took him to the operating room and was able to retrieve it after a little bit of time, and saw him on the floor in the hospital. He was admitted for a little bit afterwards to get some antibiotics, and expected to have a pretty difficult dressing change. I thought it would be really uncomfortable, and he did great with it. And I said, how are you doing? And he said, I had 5 pieces of pizza. So I always think of, it just made me smile, and I think of him when I see toothpicks.
I guess I would answer this kind of in a general sense. I can't pick out one particular patient interaction that I would say is sort of stands above the others, but you know, the greatest joy that I think you get from, and you kind of hear this from the other speakers, is, you know, when you make a difference in somebody's life, you know, you ease their suffering, their fear, you make that person-to-person connection. That's where being a healthcare provider is. That's what makes it all worth it, you know, when it's all said and done. So if you kind of yearn to kind of do something of that nature, then you won't be disappointed. So.
Thank you so much. There's a couple more questions in the chat that we will get to. We're just gonna go through our case real quick just to make sure that we get through it. And so I'm gonna turn this over to the 4 of you to kind of talk through 2 different limb salvage cases.
Don't know if Laura, oh, there she is.
All right. So I picked out a case that sort of illustrated our role in the hospital, and then also how we work with vascular and infectious disease on taking care of different patients. So this is a 70-year-old male with a history of diabetes, kidney disease, high blood pressure. He presented to the emergency department. He had a gangrenous, so a black and infected left great toe. A month prior, he was shoveling in the snow and couldn't feel the toe. He was wearing new boots that rubbed on the toe, and he developed a wound that turned black. So presents with this black toe, foul-smelling drainage from the forefoot, and some redness extending up the foot. Physical exam. So he was examined by, we work with the orthopedic residents in the emergency department. He had non-palpable pulses in his foot, so couldn't feel a pulse in the foot. Swelling and redness from the left great toe extending up the foot, and then dusky, so just looking kind of dark skin around the big toe with some odor. The wound he had on the toe when examined extended down to the bone, and there's some purulent drainage that was able to be expressed. Really didn't want his foot touched due to pain. So just some pictures. You can see the big toe there is black. The picture on the right shows the duskiness, so that clues you in that he's not getting great blood flow there, and then some redness extending up the foot. He had vitals taken when he presented to the emergency department. Looked pretty good. Those pulse was elevated. And then he had an elevated white blood cell count, which tells you there's an infection going on. He had x-rays taken, and they showed some erosive changes to the bone. So it shows that the infection's starting to wear away at the bone. And then what we call soft tissue emphysema, which can mean that there's a pretty aggressive bacteria present. And then due to the fact that they had trouble feeling his pulses in the foot, we got some vascular imaging, which Dr. Ferranti will talk about a little later on. So plan was he was diagnosed with wet gangrene, which differentiated from dry gangrene means infection that really needs to be addressed pretty quickly. The orthopedic residents did an IND at the bedside to control the infection, took some cultures to help us guide our antibiotic treatment, had a vascular workup, was started on antibiotics, and we asked infectious disease to get involved. And we took him to the operating room and performed a transmetatarsal amputation, so taking off the front part of the foot. Hospital course, this is something that Dr. Merena and I worked together on. We try to cover patients in the hospital depending on who's available. He did the initial surgery to do the transmetatarsal amputation to control the infection. Vascular came in and helped evaluate his blood flow. After that, we took him back again to clean out any remaining infection, revised some of the bone cuts, and put a wound vac machine on, which is a machine that helps big wounds heal from the inside out. And then infectious disease helped us pick out the right antibiotics. He was on antibiotics throughout his hospital course, and then didn't need them when he was sent home because the remainder of the foot was healthy. So we take some samples of the foot and send that to the lab, and they told us that we got all the infection out.
So this is a picture of that same gentleman's angiogram. So an angiogram is pictures of the blood vessels. There's what we call diagnostic angiograms, which is just basically taking a look to see where the problems are. And then there's procedures that we can actually do from the inside of the blood vessels to try to make the blood vessels better. So on the far left, there's, this is called the superficial femoral artery. It's Ideally, a healthy artery should look kind of like a straight tube. There shouldn't be any sort of shagginess to the side wall of the vessel. It should be kind of like a straight pipe. And so that actually on the left side looks really good. There's a little bit of calcium in his blood vessels, but nothing that's blocking off the blood vessel completely on that side. And then as the blood vessel comes down, we change its name to the popliteal artery as it goes behind the knee. And then in the middle picture is sort of the continuation, if you could put this one at the end of the other one. So the popliteal artery comes down and it splits off. It should split into 3 blood vessels that should be straight shots down to the foot. And as you can see, sort of the outer 2 of the 3 sort of fizzle out. And then the one in the middle, which is the perineal arteries, is actually pretty healthy going down to the foot, which we find in folks who have pretty significant diabetes. For whatever reason, the perineal artery usually is pretty robust, while the other ones can sort of get pretty significantly diseased. And on the far right, you can see all these little like kind of corkscrew collateral blood vessels, which are like, basically this patient's foot has realized that the highways are blocked off. So they made some side roads to get around, if you will.
So the hospital course, the patient had the infection cleared, had the proper wound care, right antibiotics. He was discharged to a skilled nursing facility to help with him staying off the foot, so remaining non-weight bearing, and also get some complex dressing changes. And then he followed up in our outpatient clinic in podiatry for wound care. This was his first outpatient visit. So he had the front part of his foot removed. This is looking at the foot and the heels behind there. You can see on the left side of the screen, that's his first metatarsal bone. And then the other metatarsals are visualized and looks like a pretty healthy wound. So looks pretty good. 4 weeks, he still has that wound vac machine on, which you can't see here. That's helping the wound to fill from the inside out. You're seeing increased coverage of the bone, nice, healthy bleeding tissue. 9 weeks out has progressed a little more. You can still see some of that first metatarsal bone that's visualized though. So we want to really get that covered. And then a few weeks later, it looked about the same, still with some exposed bone. So we talked with the vascular team and decided to take him back to the operating room. My role in it was taking the bone back a little bit further to nice healthy bone, putting on a graft. It was a synthetic graft called Integra. And then before I did my part of it, the vascular surgeon attempted to get him some more blood flow down to the foot to give him the best chance of healing. We also spoke with infectious disease at that time too, to see if they thought we should put him back on antibiotics, but we decided since it looked healthy to save him the risk of that and kept him off antibiotics. So this was 1 week after that second surgery. This is the graft. It's sutured down, so it's stitched down there. That top layer is a silicone layer that covers up the good graft stuff underneath. And this is 3 weeks after the second surgery, really filling in well, bones covered. So looking really good. And 2 months after the revision surgery, 6 months after the original surgery in the hospital, he was healed. I just saw him not too long ago. So 5 years after the initial surgery, still healed. I see him, I think every 3 months just to keep an eye on things and keep an eye on something on his other foot. But this foot has been doing great. He hasn't had any other concerning spots. He's walking around in a shoe. He's pretty active. He has a special orthotic for his shoe that prevents him from moving around to prevent any new wounds from forming, but doing great.
This is a second case, which is actually kind of similar to Dr. Stone's case. And I just wanted to preface a little bit about the limb salvage. When we talk about patients who are in need of limb salvage, We don't necessarily always get to keep all of the foot. Sometimes people lose toes. We kind of take that at what it is, to keep the heel and to keep the majority of the foot to allow patients to walk and be independent. And the goal is to sort of keep their ankle joint, because patients who need higher levels of amputations, like a below the knee amputation or above the knee amputation, require a lot more energy to walk the same way that somebody who just has lost a couple toes can walk. And some of those patients actually with different levels of amputation aren't actually able to walk afterwards, depending on how many other troubles they have and how strong they are. So this gentleman is a 74-year-old gentleman who has a lot of medical troubles, has heart disease, had open heart surgery. He had kidney disease and got a kidney transplant. He had carotid disease and had carotid endarterectomies, high blood pressure, diabetes, a seizure disorder, and he came in with an infected toe also and some surrounding infection of his foot. And so actually the orthopedic team first took off the infected toe and opened up the wound to help get rid of the infection and make sure that the infection didn't spread to the rest of his leg. And then once that was done, I took him for an angiogram. And so this picture here just kind of shows what the blood vessel should look like. There's the popliteal artery that splits into the 3 tibial blood vessels. And so ideally, like I said before, that should be kind of straight tubes that go down to the foot. And here you can see what his picture looked like. There's a lot of sort of calcium projections into the blood vessel. It doesn't look like a straight tube. And then on the far right, you can see that that blood vessel that should go straight down to his foot kind of stops about, right about there. And then when you go back up to where that one split off, there's a big blockage there before the blood vessel splits again. And so if you go to the next slide, we're actually able to get across the blocked area and put a small, we actually used a coronary stent because the blood vessel is so small there. So now we call it inline flow down to the foot to really get the best perfusion for wound healing. And so you can see sort of what he started with after the infected tissue was removed in the center of the screen. And then this was several months later, his wound was slowly healing. And then ultimately we were able to get his wound completely healed, which was great. And throughout all of this, he required a lot of assistance from our infectious disease colleagues. He initially was on pretty strong, what we call broad spectrum antibiotics, or the antibiotics that'll treat almost anything. And then once we had some tissue to decide what bacteria were actually growing in there, we were able to say, okay, maybe you don't need such strong antibiotics anymore, but you still need ones that will treat the bugs that are growing in your foot. And so he was on those for, I believe, 6 weeks, if not longer, before he ultimately was transitioned just to oral medicine.
All right, thank you so much. And so we're going to just pick back up with our questions. And again, if anyone has questions about the cases or anything before, please put them in the chat. One of the questions for really all of you to speak on is, does your job bring you a lot of stress? And what are ways that you deal with that stress?
So I would say yes. It's the short answer. I mean, you will experience stress, no doubt about it. And sometimes the stress is due to a particular patient that you are maybe struggling with, or just really having to put extra time in with. Other times it can be non-patient related type stress, in the sense of navigating through a healthcare system, things of that nature. Things come up, and with a in an institution, you have to sometimes be patient, and certain things you can try to be proactive about, and other things you have to kind of be patient with, I guess is the best way of putting it. But, you know, stress is a normal thing that you're going to deal with.
I might be controversial and say no. I mean, acknowledging that, yes, we all have stress, and everybody on this call has certain stressors, but yeah, I mean, I don't know. I think I'm also sufficiently at a sufficiently early part of my career where yes, there's plenty of things, institutional things sometimes it's a very challenging patient. But I guess it probably speaks better, or maybe I'm trying to speak more to I think there was a second question about like, would you do it again? And again, I'm pretty new to this, but I totally would. I do think it's something I'm really passionate about, and I think everyone seems really passionate about their specialties that they've chosen, but it also does afford me the luxury of being able to do other stuff, like spend a lot of time with family and play music. And so I don't know, I think everybody goes through periods where they question it and maybe try something different. Maybe they'll switch to something different, something different within their specialty. Yeah, I think IDs can be stressful just as everything else can, but it's also super rewarding too.
I think stress is kind of a normal part of any job. I always like to think when I was in medical school and I came home from a really hard rotation, and I was talking to my parents, and my dad's an engineer and my mom is a nurse, and my mom was a nurse in the ICU and took care of critically ill patients. And I always thought it was interesting when my dad would complain about how stressful his day was with his project he was working on. And my mom would listen to him and, you know, give him reassuring things. And he knew that she actually was just taking care of somebody who died in the ICU. And so I feel like everybody has stressful parts of their day. And I feel like if there wasn't any stress, then you wouldn't realize that the non-stressful parts were non-stressful. So I think a better question is it worth it? And I think the answer for me is yes, because we get to save lives and save people's legs. And that's really cool. And not everybody can say that they do that.
I agree that the stress exists, and it's very important to learn how to manage it and how to take care of yourself. And also really helpful to have a job that you work with colleagues that you enjoy being around and working with. And to answer the second question, I would do it again. Really, really like what I do.
Wow, thank you so much. It's so great to hear that you're all very passionate about what you do. I had a question just referring back to the case studies, and it might be semi-obvious, but in kind of both the first and the second case studies that were presented, this infection kind of started in just a toe, but then a large portion was amputated. And I was just wondering, like, how it's decided how much of the foot is going to be removed, and how you make that decision of whether to keep a couple of the toes or to remove a much larger portion. So just kind of like that process of deciding where the amputation occurs.
I can try to answer that. I think, you know, there's a lot of variables that would indicate level of amputation. I think when you're approaching a foot that has a bad infection, your first goal is to control the infection. And you know, sometimes that's with an amputation right off the bat, and other times you may not need to necessarily jump towards, and like in the cases presented, loss of the front of the foot. You know, making sure that at whatever level that you may choose to do a surgery, you know, in the case of the front of the foot, you have to make sure there's enough blood flow for healing. So really the team approach is essential. But getting input from you know, everybody involved in the sense of you know, can you do a distal procedure just involving the toes, or do you need to go more proximal? You know, there's a lot that I think goes into making that final decision and presenting it to the patient so that they clearly understand, you know what they what's going to happen.
Thank you. And just a kind of piggybacking off that, with the cases you demonstrated, is that we obviously get to see how you work together, but are there other components and other professionals who also contribute to a limb salvage team, like physical therapists and just other roles contributing?
I think, you have to take care of the whole patient and so the nursing care is super important. The wound care, which sometimes is done by visiting nurses who can come to patients' houses to help. The nutrition component is huge. So there's dietitians who see patients in the hospital. The endocrinologists are phenomenal, especially for folks who have diabetes, and they help really control people's blood sugars so that they can encourage wound healing. The physical therapists are important. It's sort of everybody plays a role in helping to get the patient healed up.
And then I have a question for Dr. Bullis, which is kind of going back to more the first section and talking about your responsibilities. But as an infectious diseases physician, are you like identifying the specific like pathogen that is that you see in infections, and as well as like determining the proper treatment? Is that something that you do, like both of those aspects of identifying and just like deciding which antibiotic and things like that? Or is that a role with a different type of physician as well?
Yeah, I mean, we work pretty intimately with our microbiology lab, who I think doesn't often get as highlighted as much. And so in the old days, before I was born, I mean, you would still, and they still teach this in med school, but the ID doctor themselves would go down to the lab, make what's called a gram smear, look under the microscope, say what bacteria are we dealing with here. A lot of that's changed with the modern microbiology labs, such that we can do that, and we still try to go down to the lab and look at stuff, but realistically the lab is filled with tons of technicians whose specific job it is to do that, and not just with bone infections or skin infections like we're talking about tonight, but urine and cerebrospinal fluid around your brain and sputum from your lungs. So we try to get involved, but it ends up mostly being conversation with the lab, doing special tests if it's not immediately apparent what the bacteria is, because obviously there's zillions of things out there. Deciding whether we need more testing, and then where we really come in is we know what we're dealing with. Let's decide what's the best treatment plan for that person. So.
Thank you. And I have a question just for, again, podiatry. I know we've talked about how podiatry, often people don't know as much about it. And I wanted to know what your advice would be for students who think they might be interested in a career in podiatry.
I think like anything in medicine, it's great to shadow to get an idea of, and you can shadow multiple podiatrists. We all do things a little bit differently and have different practices, but shadowing is definitely very helpful. Looking up on the website, reading about different schools. Those would be my big recommendations.
And I have a question for Dr. Ferranti, like in terms of the vascular portion. You were showing some different types of aneurysm repairs to the aorta and the abdomen, and you kind of showed the much more invasive versus lesser invasive. And I'm assuming that the less invasive one is probably preferred, especially for patient recovery. So I was wondering what type of circumstances would kind of require the much more invasive one, where you said you were moving all the organs and everything like that.
Good question. A lot of it has to do actually with the shape of the aneurysm and how much healthy blood vessel is above and below it. When we put the stents in, we basically rely on the stent holding up against healthy blood vessel above the aneurysm and sealing against healthy blood vessel below the aneurysm. And so the picture there shows it as a fairly uniform aneurysm, but when you actually, different people's aneurysms have different shapes to them, and they're also can be close to important blood vessels. And so if you don't have enough healthy aorta below the arteries that go to the kidneys, then you can't put the stent in as it is because it won't make a good seal. And you really want to seal the aneurysm off from the aortic blood flow. And so there's actually some really cool new techniques that people are doing to basically, they call it fenestrate the graft, which basically is you make holes in the graft that are perfectly lined up with the patient's kidney arteries or blood vessels that go to their intestines. And then you put special stents in those so that you can actually put the stent higher up, but not cover up any of the important blood vessels. So it's actually, there's some really cool technology that's growing in vascular, which is actually one of the reasons why I really like it. But so if you aren't able to do those techniques, then sometimes we have to do the open aneurysm repair because you don't want to cover somebody's kidney arteries or their blood vessels that go to their intestines.
Thank you.
Yeah.
And then I have a final question for the four of you that we love to ask our speakers. And it is, what's your favorite part about working at UVM Medical Center and with the Vermont population?
I think I can go. Mine's pretty easy. I think we have a tremendous group of ID doctors here, and the culture, well, not the culture, but the just the general atmosphere in the department is incredibly supportive of everyone. And I think that's probably true at UVM in many different departments, but we often just bounce ideas off each other in challenging cases. So I think that's huge. The population, I think it's Vermont in particular. I mean, I don't know specifically like what's the most rewarding part of serving that population, but just, I guess, feel like we do have a lot of, especially outside of Chittenden County, a lot of disenfranchised and, a lot of people who don't have a lot of, just a lot of insight into their own health. And so I guess feeling like you can really make a difference in those people's lives, specifically from an infectious disease portion. We have a lot of patients who are struggling with all sorts of things, both, socioeconomically and emotionally. And so I think just that population is anywhere, but that's really rewarding for us. Our clinic, just one last sort of brief tangent about our clinic is our HIV clinic is what's called a Ryan White clinic, which means we get federal money to have basically many different services offered. So it's not just doctors, but we have a social worker, we have a nutritionist, we have a mental health care provider. We have a nurse whose job it is to ensure adherence to HIV meds. So I think that's really rewarding too, is just having a sort of a medical type home right in our own ID clinic. So.
For me personally, I found Vermont when I was a medical student here to be just lovely. The people here actually seem really happy and really friendly, and like they work well together, which you don't always see in a lot of academic institutions. And so I think Vermont is unique in that people come and kind of realize how awesome it is and they kind of want to stay. And so you see a lot of providers here who have been here for a long time, which isn't usually the case for a lot of academic medical centers. So I think it's really nice that we have a great group of people who all are pretty, nice and reasonable and respectful and work well together. And I think the patients also are actually pretty great when it comes to, trying to do what you've asked them to do and, being respectful and doing the best they can with what they have. So I think it's a great place and a great group of people.
One of the things I like most about working at the medical center, and part of the reason I chose the job in academic institution, is it's easy to reach out to colleagues. You can call an infectious disease and get their advice on antibiotics, call vascular and ask them for their help with a patient. It's really easy to reach out to your colleagues, and everybody's very helpful. And I think that just provides the best care for the patient. What I like best about the patient population, get to know your patients really well. You see their aunt, you'll see their mom, you may see someone's cousin. And so you just get to really know families well. And I really enjoy that part of the job.
I would, I would echo some of what people have already said, in the sense of Vermont is a beautiful place to live. I've been up here for, this will be my 23rd year, and I wouldn't envision practicing anywhere else. I have no desire to leave Vermont. I think the work-life balance in Vermont is something that a lot of people value, and maybe that's not so easy to necessarily do in other places to the same extent. As far as, specific to the medical center, the thing that I would say I value the most is being able to interact with students, residents, try to be a part of their postgraduate training, try to bestow, at this point in my career, kind of give what I can to that next generation of providers, even though they're not necessarily podiatrists. And that connection with that next generation of providers, I find very valuable as far as my practice.
Well, I just wanted to say thank you again to our wonderful speakers. It was so great to hear from all of you and, your various professions that are able to be intertwined. And thank you to all the participants for joining us tonight. And this will be again posted to YouTube for reference. And join us next month on February 17th, and we will be spotlighting some nurse practitioners. But thank you again, everybody, and I hope you all have a wonderful night.
Thank you so much.
Thanks, everyone.
Thank you.
Guys.